Hello everyone, and welcome to another chapter of Advanced Pharmacology. Today we're talking about Chapter 30, Drug Abuse, Part 1, the Basic Considerations. So, some basic considerations. Mind-altering drugs have intrigued human beings since the dawn of civilization. Throughout history, people have taken drugs to elevate mood, release inhibitions, distort perceptions, induce hallucinations, and modify thinking. Many of those who take mind-altering drugs restrict use to socially approved patterns. However, many others self-administer drugs to excess. Excessive drug use is our focus in this chapter, and the three that follow. Drug abuse extracts a huge toll on the individual and on society. Tobacco alone kills about 440,000 Americans annually. Alcohol and illicit drugs kill another 100,000. In addition to putting people at risk for death, drug abuse puts them at risk for long-term illness and impairs their ability to fulfill role obligations at home, school, and work. The economic burden of drug abuse is staggering. The combined direct and indirect cost from abusing nicotine, alcohol, and illicit substances is estimated over $700 billion each year. Drug abuse confronts clinicians in a variety of ways, making knowledge of abuse is necessary. Important areas in which expertise on drug abuse may be applied include the diagnosis and treatment of acute toxicity, diagnosis and treatment of secondary medical complications of drug abuse, facilitating drug withdrawal, and providing education and counseling to maintain long-term abstinence. Our discussion for drug abuse occurs in two stages. In this chapter, we discussed a basic concept in drug abuse. Chapters 31 through 33 will focus on the pharmacology of specific abused agents and methods of treatment. So, its definition, drug abuse. Drug abuse can be defined as using a drug in a fashion inconsistent with medical or social norms. Traditionally, the term also implies drugs or drug use that is harmful to the individual or society. As we shall see, although we can give abuse a general definition, deciding whether a particular instance of drug use constitutes abuse is often difficult. Whether or not drug use is considered abuse depends in part on the purpose for which a drug is taken. Not everyone who takes large doses of psychoactive agents is an abuser. For example, we do not consider it abuse to take large doses of opioids long term to relieve pain caused by cancer. However, we do consider it abusive for an otherwise healthy individual to take those same opioids in the same doses to produce euphoria. Abuse can have different degrees of severity. Some people, for example, use heroin occasionally, whereas others use it habitually and compulsively. Although both patterns of drugs use are socially condemned and therefore constitute abuse, there is an obvious quantitative difference between taking heroin once or twice and taking it routinely and compulsively. So please note that, by the previous definition, drug abuse is culturally defined. Because abuse is culturally defined, and because societies differ from one another and are not changeable, there can be a wide variation in what is labeled abuse. What is defined as abuse can vary from one culture to another. Another example, in the US, moderate consumption of alcohol is not usually considered abuse. In contrast, any ingestion of alcohol may be considered abuse in some Muslim societies. Furthermore, what is defined as abuse can vary from one time to another within the same culture. Another example is when a few Americans first experimented with lysergic acid diethylamide or LSD and other psychedelic drugs. These agents were legal, and their use was not generally disapproved. However, when use of psychedelics became widespread, our societal posture changed, and legislation was passed to make the manufacture, sale, and use of these drugs illegal. As we can see, distinguishing between culturally acceptable drug use and drugs used that is to be called abuse is more in the realm of a social science than a pharmacology. Accordingly, because this is a pharmacology textbook and not a sociology text, we will attempt to define just what patterns of drug use do or do not constitute abuse. Instead, we will focus on the pharmacologic properties of abused drugs. Fortunately, we can identify the drugs that tend to be abused and discuss their pharmacology. So, let's talk about addiction. According to the National Institute of Drug Abuse, addiction is defined as a chronic, relapsing brain disease that is characterized by compulsive drug seeking and use despite its harmful consequences. Addiction is a very complex phenomenon that includes social, psychological, genetic, and environmental components. So please note that somewhere in the definition is addiction equated with physical dependence. As discussed later, although physical dependence can contribute to addictive behavior, it is neither necessary nor sufficient for addiction to occur. Other definitions that we should know about: tolerance. Tolerance results from regular drug use and can be defined as a state in which a particular dose elicits a smaller response than it did with the initial use. As tolerance increases, higher and higher doses are needed to elicit the desired effect. Cross tolerance is a state in which tolerance to one drug confers tolerance to another. Cross tolerance generally develops among drugs within a particular class, and not between drugs in different classes. So, an example of this would be tolerance to one opioid, such as heroin, which confers a cross tolerance to other opioids, including morphine, but not to central nervous systems depressants, so your psychostimulants, psychedelics, or nicotine. Psychological dependence can be defined as the intense subjective need for a particular psychoactive drug. Physical dependence can be defined as a state in which an abstinence syndrome will occur if the drug is discontinued. Physical dependence is a result of a neuroadaptive process that takes place in response to prolonged drug exposure. Cross-dependence refers to the ability of one drug to support physical dependence on another drug. When cross-dependence exists between drug A and drug B, taking drug A will prevent withdrawal in a patient physically dependent on drug B, and vice versa. As with cross-tolerance, cross-dependence generally exists among drugs in the same pharmacologic family, but not between drugs in different families. And finally, withdrawal syndrome, which is a constellation of signs and symptoms that occur in a physically dependent individual when they discontinue drug use. Quite often, the symptoms seen during withdrawal are opposite to the effects the drug produces before it is withdrawn. So, an example of this would be the discontinuation of a CNS depressant, which would cause CNS excitation. Which brings us to the diagnostic criteria regarding drugs of abuse. Substance use disorder is defined as continued use of a substance despite significant substance-related problems. There exists a change in brain circuitry that persists despite detoxification. Diagnosis of substance abuse disorder is based on behavior related to continued use of a substance. Tolerance and withdrawal are among the criteria established by the American Psychiatric Association for having a substance use disorder. Please note, however, that tolerance and withdrawal by themselves are neither necessary nor sufficient for a substance use disorder to exist. Put another way, the pattern of drug use that constitutes a substance use disorder can exist in a person who are not physically dependent on drugs and who have not developed tolerance. This distinction is extremely important. Being physically dependent on a drug is not the same as being addicted. Many people are physically dependent but do not meet the criteria for substance use disorder. These people are not considered addicts because they do not demonstrate the behavior pattern that constitutes substance dependence. Patients with terminal cancer, for example, are often physically dependent on opioids. However, Because their lives are not disrupted by the medication, their drug use does not meet the criteria for a substance use disorder. Similarly, some degree of physical dependence occurs in all patients who take a phenobarbital to control seizure disorder. Again, however, despite their physical dependence, patients with seizures do not carry out stereotypic addictive behavior and therefore do not have a substance use disorder. Having stressed that physical dependence and addiction are different from each other, we must note that the two states are not entirely unrelated. Again, as discussed later, the physical dependence is not the same as addiction. Physical dependence often contributes to addictive behavior. So, factors that contribute to drug abuse. Drug abuse is the end result of a progressive involvement with drugs. Taking psychoactive drugs is usually initiated out of curiosity. From this initial involvement, the user can progress to occasional use. Occasional use can then evolve into compulsive use. Factors that play a role in the progression from experimental use to compulsive use will be discussed next. So, reinforcing properties of drugs. Reinforcement by drugs can occur in two ways. First, drugs can give the individual an experience that is pleasurable. Cocaine, for example, produces the state of euphoria. Second, drugs can reduce the intensity of unpleasant experiences. So, an example of that would be drugs that reduce anxiety or stress. The reinforcing properties of drugs can be clearly demonstrated in experiments with animals. In the lab, animals will self-administer most of the drugs that are abused by humans. So, opioids, barbiturates, alcohol, cocaine, amphetamines, phenylcyclidine, nicotine, and caffeine. When these drugs are made freely available, animals develop patterns of drug use that are similar to those of humans. Animals will self-administer these drugs in preference to eating, drinking, and sex. When permitted, they will often die of lack of food and fluid. These observations strongly suggest that pre-existing psychopathology is not necessary for drug abuse to develop. Rather, these studies suggest that drug abuse results in large part from the reinforcing properties of the drugs themselves. Which brings us to the physical dependence. Again, as defined earlier, physical dependence is a state in which an abstinence syndrome will occur if the drug is discontinued. The degree of physical dependence is determined largely by dosage and duration of drug use. Physical dependence is greatest in people who take large doses for a long time. The more physically dependent a person is, the more intense the withdrawal syndrome. Substantially, physical dependence develops to the opioids. Again, your morphines and heroines, and CNS depressants, your barbiturates and alcohol. Physical dependence tends to be less prominent with other abused drugs, so your psychostimulants, your psychedelics, and marijuana. Physical dependence can contribute to compulsive drug use. After dependence has developed, the desire to avoid withdrawal becomes a motivator for continued dosing. Furthermore, if the drug is administered after the onset of withdrawal, its ability to alleviate the discomfort of withdrawal can reinforce its desirability. So please note, again, that although physical dependence plays a role in the abuse of drugs, physical dependence should not be viewed as the primary cause of addictive behavior. Rather, physical dependence is just one of the several factors that contribute to the development and continuation of compulsive use. So, that brings us to the psychological dependence. Psychological dependence is defined as an intense subjective need for a drug. Individuals who are psychologically dependent feel very strongly that their sense of well being is dependent on continued drug use. A sense of craving is felt when the drug is unavailable. There's no question that psychological dependence can be a major factor in addictive behavior. So, examples of this would be it is a psychological dependence and not a physical dependence that plays the principal role in causing renewed use of opioids by addicts who have previously gone through withdrawal already. Social factors. Social factors can play an important role in the development of abuse. The desire for social status and approval is a common reason for initiating drug use. Also, because initial drug experiences are frequently unpleasant, the desire for social approval can be one of the most compelling reasons for repeated drug use after the initial exposure. Examples of these: most people do not especially enjoy their first cigarette. Were it not for peer pressure, many would quit before they smoked enough to become pleasurable. Similarly, the initial use of heroin, with its associated nausea and vomiting, is often deemed unpleasant. Peer pressure is a common reason for continuing heroin use long enough to develop tolerance to the undesirable effects. Drug availability. Drug availability is clearly a factor in the development and maintenance of abuse. Abuse can flourish only in environments where drugs can be readily obtained. In contrast, where procurement is difficult, abuse is minimal. The ready availability of drugs in hospitals and clinics is a major reason for the unusually high rate of addiction among pharmacists, nurses, and physicians. Vulnerability of the individual. Some individuals are more prone to becoming drug abusers than others. By way of illustration, let's consider three individuals from the same social setting who have equal access to the same psychoactive drug. The first person experiments with the drug briefly and never uses it again. The second person progresses from experimentation to the occasional use, while the third goes on to take the drug compulsively. Because social factors, drug availability, and the property of the drug itself are the same for all three people, these factors cannot explain the three different patterns of drug use. We must conclude, therefore, that the differences must lie in the people. One individual was not prone to drug abuse, one had only moderate tendencies towards abuse, and a third was highly vulnerable to becoming an abuser. Several psychological factors have been associated with tendencies towards drug abuse. Drug abusers are frequently individuals who are impulsive, have a low tolerance for frustration, and are rebellious against the social norms. Other psychological factors that seem to predispose individuals to abusing drugs include depressive disorders, anxiety disorders, and antisocial personalities. It is also clear that individuals who abuse one type of drug are likely to abuse other drugs. There is speculation that some instances of drug abuse may actually represent self medication to relieve emotional discomfort. So, examples of that would be some people may use alcohol and other depressants to control severe anxiety. Although the drug use may appear excessive, it may be no more than they need to neutralize intolerable feelings. Genetics also contribute to drug abuse. Vulnerability to alcoholism, for example, may result from an inherited predisposition. Which brings us then to the neurobiology of addiction. Repeated use of an addictive drug contributes to the transition from voluntary drug use to compulsive use by causing molecular changes in the brain. Each time the drug is taken, it causes changes that promote further drug use. With repeated drug exposure, these changes are reinforced, making drug use increasingly more difficult to control. Molecular changes occur in the reward circuit, a system that normally serves to reinforce behavior essential for survival, such as eating and reproductive activities. Neurons of the reward circuit originate in the ventral tegmental area of the midbrain and project to the nucleus accumbens. The major transmitter is dopamine. Under normal circumstances, biologically critical behavior, such as sexual intercourse, activates the circuit. The resultant release of dopamine rewards and reinforces the behavior. Like natural positive stimuli, addictive drugs can also activate the circuit and therefore cause dopamine release. In fact, drugs are so effective at activating the circuit that the amount of dopamine released may be 2 to 10 times the amount released by natural stimuli. Ultimately, whether the system is activated by use of drugs or by behavior essential for survival, the outcome is the same: a tendency to repeat the behavior that turned the system on. With repeated activation over time, the system undergoes synaptic remodeling, thereby consolidating changes in brain function. This neural remodeling persists after drug use has ceased. An important aspect of drug-induced remodeling is a phenomenon known as downregulation, which serves to reduce the response to drugs. Because drugs release abnormally large amounts of dopamine, the reward circuit is put in a state of excessive activation. In response, the brain produces less dopamine and reduces the number of dopamine receptors. As a result, responses to the drugs are reduced. Unfortunately, the ability of natural stimuli to activate the circuitry is reduced as well. In the absence of a pleasurable feeling from natural stimuli, the abuser is left feeling flat, lifeless, and depressed. The good news is that when drug use stops, neural remodeling tendencies gradually reverse. Which brings us to the principles of addiction treatment. Drug addiction is a treatable disease of the brain. With therapy, between 40 to 60% of addicts can reduce drug use. The first science-based guide on addiction therapy, Principles of Drug Addiction Treatment, was published by the National Institute of Drug Abuse in 1999, which was later revised in 2009 and again in 2012. The guide centers on 13 principles of effective treatment, shown in the following box. So I'll pinpoint some of the bullet points, and if you would like to hit pause and read some of the rest of it, you're more than welcome to. So, the principles of drug addiction treatment. Addiction is a complex but treatable disease that affects the brain function and behavior. No single treatment is appropriate for everyone. Treatment must be readily available. Effective treatment must attend to multiple needs of the individual, not solely drug use. Remaining in treatment for an adequate time is critical, and the time period there is 3 months. Individual and/or group counseling and other behavior therapies are the most common forms of drug abuse treatment. Medication can be an important element of treatment, especially when combined with counseling and other behavior therapies. Because needs of the individual can change, the plan for treatment and services must be reassessed continually and modified as indicated. Many drug-addicted individuals also have other mental disorders, which must be addressed. Medically assisted detoxification is the only first stage of addiction treatment and by itself does little to change long-term drug use. Treatment need not be voluntary to be effective. Drug use during treatment must be monitored continuously because relapse during treatment does occur. Treatment programs should provide assessment for HIV and AIDS, hepatitis B and C, tuberculosis, and other infectious diseases, along with counseling to help patients modify behaviors that place them and others at risk. So those are the major bullet points. Ideally, the goal of treatment is complete cessation of drug use. However, total abstinence is not the only outcome that can be considered successful. Treatment that changes drug use from compulsive to moderate will permit increased productivity, better health, and a decrease in socially unacceptable behavior. Clearly, this outcome is beneficial both to the individual and to society, even though some degree of drug use continues. It must be noted, however, that in the treatment of some forms of abuse, nothing short of total abstinence can be considered a true success. Experience has shown that abusers of cigarettes, alcohol, and opioids are really capable of sustained moderation. Therefore, many of these individuals, abstinence must be complete if there is to be any hope of avoiding a return to the compulsive use. Recovery from addiction is a prolonged process that typically requires multiple treatment episodes because addiction is a chronic, relapsing illness. As such, periods of treatment-induced abstinence will very likely be followed by relapse. This does not mean that treatment has failed. Rather, it simply means that at least one more treatment episode is needed. Eventually, many patients achieve stable, long-term abstinence along with a more productive and rewarding life. Because addiction is a complex illness that affects all aspects of life, the treatment program must be comprehensive and multifaceted. In addition to addressing drug use itself, The program should address any related medical, psychological, social, vocational, and legal problems. Obviously, treatment must be tailored to the individual. No single approach works for all people, and multiple techniques ought to be employed. Techniques with proven success include group and individual therapy directed at resolving emotional problems that underlie drug use, substituting alternative rewards for the rewards of drug use, and the use of pharmacologic agents to modify the effects of abused drugs. The most effective treatment program incorporates two or more of these methods. When possible, a specialist in addiction, medicine, or substance use should be involved in the patient's care. Which leads us to the Controlled Substance Act. The Comprehensive Drug Abuse Prevention and Control Act of 1970, known informally as the Controlled Substance Act, is the principal federal legislation addressing drug abuse. One objective of the CSA is to reduce the chances that drug originating from legitimate sources will be diverted to abusers. To accomplish this goal, the CSA sets forth regulations for the handling of controlled substances by manufacturers, distributors, pharmacists, nurses, and physicians. Enforcement of the CSA is the responsibility of the Drug Enforcement Agency, an arm of the U.S. Department of Justice. Record keeping. To keep track of controlled substances that originate from a legitimate source, a written record must be made of all transactions involving these agents. Every time a controlled substance is purchased or dispensed, the transfer must be recorded. Physicians, pharmacists, and hospitals must keep an inventory of all controlled substances they have in stock. This inventory must be reported to the DEA every 2 years. Although not specifically obligated to do so by the CSA, many hospitals use medication dispensing machines that count the controlled substance dispensed during each shift. The DEA schedules, or Drug Enforcement Agency. Each drug preparation regulated under the CSA has been assigned to one of the five categories, Schedule 1 through 5. Drugs in Schedule 1 have a high potential for abuse and no approved medical use in the US. In contrast, drugs in Schedule 2 through 5 all have approved applications. Assignment to Schedules 2 through 5 are based on the abuse potential and potential for causing physical or psychological dependence of the drugs that have medical applications. Those in Schedule 2 have the highest potential for abuse and dependence. Drugs in the remaining schedules have decreasing abuse and dependence liabilities. So the following table here lists the primary drugs that come under the 5 DEA schedules. Again, here's an excellent spot to hit pause if you're unfamiliar with different types of scheduled drugs, whether they are opioids, psychedelics, your, your cannabis derivatives, psychostimulants, barbiturates, miscellaneous depressants, your steroids, your stimulants, and the such. Scheduling of drugs under the CSA undergoes a periodic re-evaluation with increasing understanding of abuse and dependence liabilities of the drug. The DEA may choose to reassign it to a different schedule. So an example of this would be hydrocodone or Vicodin, which was recently switched from a Schedule 3 to a Schedule 2. Prescriptions. The CSA places restrictions on prescribing drugs in Schedule 2 through 5. Drugs in Schedule 1 have no approved use and therefore are not prescribed. Only prescribers registered with the DEA are authorized to prescribe controlled drugs. Regulations on prescribing controlled substances are summarized next. So, if it's a Schedule 2 drug, all prescriptions for Schedule 2 drugs must be typed or filled out in ink or indelible pencil and signed by the prescriber. Alternatively, prescribers may submit prescriptions using an electronic prescribed procedure. Oral prescriptions may be called in, but only in emergencies, and written prescriptions must follow within 72 hours. Prescriptions for a Schedule 2 drug cannot be refilled. However, a DEA rule issued in 2007 now allows a prescriber to write multiple prescriptions on the same day for the same patient and the same drug, to be filled sequentially for up to 90-day supply. Schedule 3 and 4. Prescriptions for drugs in Schedule 3 and 4 may be oral, written, or electronic. If authorized by the prescriber, the prescriptions may be filled up to 5 times. Refills must be made within 6 months of the original order. If additional medication is needed beyond the amount provided for in the original prescription, a new prescription must be obtained and written. Schedule 5. The same regulations for prescribing drugs in Schedule 3 and 4 do apply to Schedule 5. However, in addition, Schedule 5 drugs may be dispensed without a prescription provided the following conditions are met. The drug is dispensed by a pharmacist, the amount dispensed is very limited, the recipient is at least 18 years of age, the pharmacist writes and initials a record indicating the date, the name and amount of the drug, and the name and the address of the recipient. And finally, state and local laws do not prohibit dispensing Schedule 5 drugs without a prescription. Labeling. When drugs in Schedule 2, 3, and 4 are dispensed, the containers must bear this label. Caution. Federal law prohibits the transfer of this drug to any person other than the patient for whom it is prescribed. State laws. All states have their own laws regulating drugs of abuse. In many cases, state laws are more stringent than federal laws, so as a rule, whenever there is a difference between a state and a federal law, the more restrictive of the two takes precedence. And that completes our chapter here for today. I thank you as always for listening, and I'll see you in chapter 31. Take care and have a good day.